Hi, it's Peyton Rupel. I did my master's project on the pulmonary manifestations of cystic fibrosis. In this presentation, we'll review the general features, clinical assessment, diagnosis, and the treatment of CF. Etiology and pathophysiology. CF is an autosomal recessive disease diagnosed as a mutation in the CF transmembrane conductase regulator protein, responsible for regulating chloride, sodium, and bicarb transport in exocrine tissues. This dysfunction of exocrine tissues affects not only the lungs, but the pancreas, liver, intestine, and reproductive tract. It is the pulmonary complications, though, that are the leading cause of progression, morbidity, and mortality, which is why I chose to focus on these manifestations. Signs, symptoms, and physical exam. Typical onset of respiratory symptoms begin with a cough that becomes persistent, productive, and paroxysmal. As the disease progresses and airways become damaged due to chronic infections, they eventually collapse, and obstruction results with air trapping and wheezing. The most important clinical findings are difficulty breathing and symptoms due to frequent lung and sinus infections. An exacerbation of the disease process includes worsening of cough, increased sputum production, and dyspnea. Exacerbations lead to the inability to eliminate pathogens and bacterial infections. Among common pathogens, Staph aureus, H. influ, and others, Pseudomonas is by far the most isolated cause of infection. Common physical exam findings include chronic sinusitis, nasal polyps, digital clubbing, and an increased AP diameter. Wheezes and crackles are commonly heard on auscultation, with hyperresonance on percussion. Moving on to diagnosis. Newborn screening has been especially integral in the increased average lifespan to over 40 years. Additionally, screening has increased the number of diagnoses to an average of 30,000 people in the United States diagnosed today. Newborn screening is offered to all couples planning pregnancies and recommended for those at high risk of carrying the CF mutation. This includes individuals with a personal history or an affected first or second degree family member. Populations at an increased risk include non-Hispanic whites and Ashkenazi Jews. The standard diagnostic and confirmatory test, though, is the sweat chloride test. Universal standards exist for this diagnostic criteria. Over 60 millimoles per liter for all ages is diagnostic of CF. Imaging serves as a supportive diagnosis. High-resolution CT is the most sensitive method for detecting these signs and may be used to track disease progression and severity by monitoring bronchiectasis, air wall thickening, and mucus plugging. Plain films may show hyperinflation and bronchovascular markings, which progress to bronchiectasis and cyst formation. PFTs show an obstructive pattern, and a decline in FEV1 is a vital measurement associated with diminished survival and can serve as an indicator for lung transplant evaluation. Moving on to treatment. The primary goal of treating pulmonary manifestations of CF is to preserve lung function by airway clearance therapy, drug therapy, and surgery to clear the airways and control infection. The Cystic Fibrosis Foundation states that chest physical therapy, high-frequency chest compression devices, and aerobic therapy elicit cough and improve the patient's airways. Drug therapy includes mucolytics, airway hydrators, anti-inflammatories, and antibiotics. Dornase alpha is a mucolytic recommended to improve lung function, alleviate symptoms, and decrease exacerbations. Inhaled hypertonic saline is also highly recommended as chronic management to hydrate the airways. Aerosolized antibiotics are effective for eradication of acute infections and for the suppression of chronic infections. The Cystic Fibrosis Foundation strongly recommends inhaled tobramycin for the treatment of the most common pathogen, Pseudomonas. Additional antibiotic therapy includes macrolides, specifically azithromycin. Another noteworthy treatment worth mentioning is a new class of drugs, the CFTR modulators. These drugs improve the function of the defective CFTR protein and have been shown to be markedly effective. Lung transplantation. This should be considered in patients with a high risk of respiratory failure or those who have had exacerbations resulting in ICU stays. Those with severe disease should be referred early to begin this discussion of these considerations. Moving on to lifestyle and prevention. Follow-up care and routine evaluation by multidisciplinary specialists every 2 to 3 months is needed to follow the progression and severity of the disease. At each visit, respiratory cultures are obtained, pulmonary function is tested, and oxyhemoglobin saturation is measured to monitor lung function and to determine which, if any, adjustments are warranted. As well as education on the disease process, genetic counseling should be provided at the initial diagnostic visit. And first-degree siblings, half siblings with signs and symptoms, or parents known to be carriers should undergo sweat chloride testing. It is also essential that resources for coping with this diagnosis be offered for patients and their families. It is vital that patients and their caregivers also understand the importance of compliance with medications and the prevention of infection by simple means such as hand washing, avoiding close contact with sick individuals and others with cystic fibrosis, as well as staying up with their vaccinations for influenza and pneumococcal. Now that we've reviewed the general features, clinical assessment, diagnosis, and treatment of CF, I hope that you have a better understanding for your PANCE and clinical practice. These are my references.